Hi. So welcome back to Rajavithi Queen Surrogate, live case. So we saved the best for last for all you guys, and thanks for joining until late Sunday. So we have here with me Dr. Hidehiko Kara from Toho University Hospital, Tokyo. Well, you can guess at what we're gonna do, right? So we're gonna do the PFO case. Of course, quite interesting. So, Kay, if you can share some patient history.
So slide, please. Here, our case is 59 years old male. He's presenting with the recurrent ischemic stroke 3 months prior to the hospital. And last 3 months, he presented with the left hemiparesis and discharged here with fully recovered. And then the one month prior to the hospital, he again presented with the sudden onset of the left side visual loss, which is the left homonymous hemianopia. And the patient was worked up for the emboli cause. He already done the Holter, but there's no evidence of the atrial fibrillation, and the echo was found the PFO. So the patient was sent to Rajavithi Hospital for considered PFO closure. Next slide, please. So the passive medical history is just dyslipidemia. His current medication is aspirin for 81 milligrams per day, clopidogrel 75 milligrams per day, and atorvastatin 40 milligrams per day. Next, please. So the examination, the blood pressure shows no hypertension, and the heart is regular, no atrial fibrillations without any murmur or no heaving. And the neurological, it shows the visual field defect with the left homonymous hemianopia, and all the motor is grade 5 all extremities. Please, next slide, please. So our diagnosis is recurrent ischemic stroke localized at the right occipital lobe, suspected from the embolic cause. And the etiology that we suspected the first is a cardioembolic, is a paroxysmal atrial fibrillations. But as we know, that patient already done the Holter, and the telemetry show no evidence of the atrial fibrillations. So paradoxical emboli from the PFO, this should be the cause of the stroke in these patients. So next, please. So the chest X-ray is looking good. There's no cardiomegaly, and the EKG with synapse rhythm without any right axis deviations. Next, please. So we're calculating the ROPE score system. This ROPE score in this patient is 7 point, but it's a 72 probability that the PFO is the cause of the stroke in these patients, and the Pascal classification is probable PFO-related stroke. Next, please. So our final diagnosis is recurrent ischemic stroke. This patient was related with the patent filament overlaid PFO, and our plan today with the PFO closure with the Cocoon PFO closure device.
Thanks, Kay. So for the history, any thoughts or any comments before we proceed?
Yeah. Hi, guys. So do you guys use a Pascal score?
Hi, Sahid.
Hey. Use ROPE and Pascal score. Do you rely quite a bit on it, or if you have ruled out all thromboembolic phenomena, you proceed because it is PF-related stroke?
Yeah, I think it's very clear for this particular case. It's stroke-related. PFO-related stroke. Well, we can use the score, but actually, in this particular case, I think we don't completely rely on the score. If we see the PFO, which is quite significant, I think we definitely we will go for that. Any thought on that?
Yes, in Japan the situation is similar, so we recommend using the Pascal and also the ROPE score, but it depends on the situation. So if the patient quite typical for the paradoxic stroke, but the score is going to be not such good, but we can proceed PFO closure.
Okay. Any questions from the audience about ROPE score, Pascal? Jay Young has a comment or a question.
I'm Jay Young Choi. Maybe I missed in the presentation, but do you have any imaging study for
Well,
brain?
we do, and we're going to show you in a second, Jay. Thanks for asking.
Sorry.
This is the key point we would like to show. Yes.
And is it usual for some multidisciplinary discussion with a neurologist in your hospital?
Of course, of course. I think this case actually this is a case from Rajavithi Hospital, where the team there they discussed with the neurologist, right, to sort out whether any other possibilities and also any kind of evidence showing this is likely to be ischemic stroke, which is likely from their opinion that this is ischemic stroke, right? Okay.
Thank you,
Yes.
Orakan.
Okay,
Thank
so
you.
yes, sorry. He had thanks. That's very clear, and thanks for asking, because this is one of the most important thing we need to discuss before we bring the patient into the cath lab.
Okay.
Right.
Okay.
So allow me to proceed then. So what Jay asked, just to share with you guys how we're gonna do the bubble testing, and actually without help from Hide, I think this beautiful picture cannot be happen. So okay, if you can show us, yeah, can you show the slide? Yeah, that's okay. I can say from you. Okay. Okay. Yeah. You see now, Hide, if you can explain a bit what are we doing?
Yes. So now we are performing the party balloon technique to detect the PFO. So as you see, I'm now putting the saline with a little bit blood and bubble, and then now the patient blow the balloon and also inhale the air, and then that makes the not only the valsalva maneuver, but additional Miller effect that will make the bubble very nicely to the left atrial side.
Yeah, a lot of bubble, huh? After this kind of techniques.
A lot of bubble, yeah. Almost looked like you were
Yeah.
injecting in the ventricle, left ventricle.
Yes.
Yeah, that's right.
Yes.
Yeah.
So you know that was amazed by what I have been witnessed during the CSI PFO session last April, right?
Yep.
Yeah. So with that, so that's why we do ask Hide to come here to teach us how to do the proper bubble testing.
And
Yes,
it's
usually,
important
so when
that
we
there
do
are
the-
first three
okay.
beats, right? The bubbles went from right to left in first three beats. Correct?
Exactly correct.
Right.
So, Warkan, can I ask a quick question about your current practice about how to decide the indication of the closure? So, do you always do the transesophageal echo prior to the procedure and the transcranial Doppler or something?
Well, transesophageal echo, yes. If we plan to, well, firstly, we have the history, and then it's very clear. And then secondly, we need to do bubble testing to see whether any positive thing or not. And then we go for transesophageal echo if we believe this is what the source. For transcranial Doppler, what about here? I don't think we do it routinely, right? Transcranial Doppler in Rajavithi Hospital and Central Chest Hospital. Will you do that routinely? No. Yeah. So we rely on three things: history, bubble test, and then transesophageal echo.
Okay, thank you.
Volkan, Dr.
Thank you.
Support.
How about?
Oh, yes. Yeah, that is a very good question. So to detect the only PFO, so the transthoracic echo with the party balloon or valsalva maneuver is going to be okay. But when we should look at the anatomy of the PFO itself, where we are thinking about the higher risk of some kinds of the prominent eustachian valve or atrial septal aneurysm. I think it's going to be better for us to use the transesophageal echo.
Well, there are a few more questions. Go ahead, sir.
Yeah. Volkan, Dr. Support. Yeah. I'm not sure
Capital
that the echo imaging that you do did the bubble test is came from the right to the left atrium, because the bubble is look like come from the posterior of the left atrium. I'm not sure
Oh,
that.
okay.
So I think we need
Thank you, Ajahn.
transesophageal echo to confirm that the bubble is caused from the right atrium to the left atrium.
Okay. Tao?
Definitely, Ajahn.
Tao has a question too. Hang on.
Please,
More than a
Tao.
question is a comment. Ide and my first diagnostic tool is transcranial Doppler. because the more sensitive and specific. Try to think about the posture dependency, right to left shunt in platypnea orthodoxa. How can you do with the patient in sitting position and not in upright? So I do think that is the most easy and cheap method, just to know if there is any bubbles, and then if no, probably you should avoid any kind of further examinations.
I mean, I think your
thank you
point
so
is
much
well
for,
taken.
your
The
comment.
transcranial Doppler can be falsely positive as well, right? So without
No.
any question. So
It's not possible.
if you have
Because,
AVMs,
the macro bubbles you
if
injected.
if you have AVMs, it will be positive.
No.
Yes.
I mean, let me answer you.
Go.
No false positive. Extracardiac shunts is 10 to 15 seconds after. And this is the difference. But it cannot be false positive. Is there or not? And then, if you have a late response, a late appearance of the bubbles, you should think about extracardiac. So AVP malformation, PVM.
Thank you, Tao.
Thank you.
The problem with transcranial
that's quite a-
Doppler is that once it is positive, you are going to go to the cath lab to look at the PFO. So that makes you read toward the false side of it. But anyway, so I mean, I don't think it's absolutely mandatory. It is highly sensitive. Yes. I think what you are doing here, work on all the three factors that you explained, that you're looking at the history and what the patient's symptoms are, and you have a bubble test that is positive. As long as you prove it is right atrium to left atrium, I think that's, to me, is more than good enough.
Thank you. Any other things?
Oh,
Did
yes,
anyone say?
regarding the Tao's comment, so, yeah, of course.
Dr. Dalvi has a
transcranial
comment.
Doppler is going to be okay. Oh, yes, please.
I quite agree with all the three factors you said, Varakan, but in a 59 or a 60-year-old gentleman, neuroimaging is as important to know whether it's an embolic episode or it is non-embolic.
Thank you. I can't remember, Kay, if you can say what is it imaging result for the CT or MRI? Yeah. It's a lesion at the occipital lobe. It's related to ischemia or? Okay.
So if it's a single superficial infarct, it is more likely to be embolic. However, it's a lacunar multiple deep infarcts are more likely to be atherosclerotic.
So it's single infarct, right? Not lacunar infarct. That's a single adicortical. Okay.
Okay.
Sorry, Kay doesn't have a phone.
All right, so what's the plan now?
Yeah, so the plan is, well, allow me to maybe ask Tawai to show some echo image. I mean, this is transesophageal echo. And if somebody can help me preparing the bubble test while Tawai is doing transesophageal, just to share whether it's right to left shunt or not. Patient is now under local anesthesia, so sedation. Yeah, Tawai, please.
Yep. Oh, I think we just passed the catheter, so if you do the bubble test right now, it's gonna.
Can you show from the beginning first, maybe what you recorded?
So this is the pre-procedural echo. This is the 0-degree mid-esophageal view. When we turn on the color, there's no flow across the septum and this view.
So, Tao.
We move to 45. Yep. Oh, sure. Sir?
So,
okay.
One second. Tao, using the Pascal classification, what do you think is this ASD? Oh, sorry, this PFO. Is that a high probability of or low
There is
probability?
a huge startion bubble and no hypermobility. So What the age of the patient? I didn't remember.
age of the patient อายุเท่าไหร่นะครับอายุ 59 ใช่ไหม
So Tao, this looks
59,
like
yes.
slightly tunnel, not very long, but tunnel type PFO. Would you agree?
Yeah.
Okay.
Absolutely.
Okay. And is it aneurysmal?
I don't think so. Hypermobility.
Okay.
And
So tunnel is if it's more than 8 millimeters by definition. If so, how long is this? So it's about 7. So it's not a huge tunnel. Stay close to the microphone, okay? That's good.
Okay. And
no
this is
hypertrophy of the septum.
length
No.
with
So no lapomatous atrial septum. The length of the overlap of the septum primum secundum is 7 millimeters in diameter. It is definitely not aneurysmal. There is no 10 millimeter excursion of the primum septum. So in Pascal classification, where would this fit?
Favorable.
Probable? Okay. Okay.
What about the brain NMR? I didn't. For this patient, the brain NMR. What was the finding?
They said that the findings were consistent with the ischemic stroke.
Okay.
So you're going to do another bubble test?
Yeah, just to show you guys, but now the catheter is crossing. I'm not sure whether it will be applicable or not.
Yeah, I mean, you have a PFO. The catheter has
We'll
already
try.
passed through it.
Yeah, we'll try. Yeah.
Okay, so sure.
Can you withdraw the
Yes,
catheter
I'll-
simply and do
Okay,
the
we'll
test?
do.
Because
ถอย
from
ให้
the
นิดนึงนะครับแล้ว
from the
They want you to pull the catheter back, do a bubble study, then re-advance the catheter back into
Yeah.
the left upper pulmonary vein.
it's very easy to
Sure,
recross.
sure. Yeah. Thank you, Tom.
And from the femoral
Okay, now it's
approach,
out.
the amount of
It is.
right to left shunt will be higher than from antecubital.
นะคะถอยแคทเตอร์ออกแล้วใช่ไหมครับอ๋อลองชีตแล้วด้วยถอยได้ไหมครับ
So, Warkan, are you going to pull the catheter back and do the bubble study, or are you going to proceed?
Gonna pull the catheter back then.
Okay.
In the meantime,
Jay has another comment or a question.
yeah, this question is to Hide. Hi, Hide. The
Sorry, Hide doesn't have a microphone now. I'll translate.
Okay.
I'll transfer to him,
What I
yes.
can, you can answer. The only thing I'm not sure is that this patient maybe the stroke is due to the PFO associated stroke. However, coincidentally, in such a little bit elder patient, there may be some chance of some paroxysmal AFib. So how do you how strictly screen the arrhythmia for those some a little bit elder patients?
Yeah, for this particular case, they do Holter and also they do telemetry, and they did not find any evidence of arrhythmia, I mean atrial flutter. So the question to you, Hide,
Yep.
how comprehensive you think for the elder patient that we should look for the atrial fibrillation?
Oh, yes, that is a very good question. So when we look at the randomized trial, the evidence of the atrial fibrillation occurring after the procedure is very low. But majority in Japan, when we look at the PMS data of the blood PFO Closure, 30% of the patients are greater than 60 years old. So, but the AFib prevalence is very low. I think, if the patient has a risk of the AFib, I think we need to follow up the like a Holter monitoring or something.
Prolonged, there
Next
are
year,
so many prolonged monitoring devices nowadays. So
Guys, I would continue doing it too because we don't want to run out of time as well. So if you want to continue to do the bubble study while we're having this nice discussion, please do. I still see the catheter across, right?
So I'm sorry to say that now the patient, because we do under local anesthesia, and patient has been, putting the TOE for about 40 minutes, and
Wow.
he is not able to tolerate it quite properly. So would that be okay if we skip the bubble test because we have to take the sheet out completely and then just reinsert it again?
I think from my perspective, it's completely okay to skip the bubble test.
yeah,
you're
sorry
across
for
the
that,
PFO.
but yeah,
And Tao
yeah, we
approves it.
crossed PFO already, and
Okay. So
Thank
now,
you.
yeah, we're going to figure out you're going to use a cocoon device, correct?
yeah, it's a cocoon device, what we plan for, and if you can have a look on this sheet.
And, let's go through the algorithm of how will you size this type of PFO. What size device are you going to put in? And what size cocoon devices are available for the audience?
So can you see the chart?
Well, you can verbally tell us or show, probably it's better if you tell us verbally.
Can you show this one?
Crystal clear now.
This is a chart of the cocoon device. So
We can't
the
read.
PFO cocoon device is an nitinol platinum coat with the size wise have around here 6 size available right now. So start from 18, right did 18, left did 18, and right disc 25 have 2 different left atrial discs, which is 18 and 25. Next is the right side 30, the left side 25 and 30,
Okay.
and then 35, 35.
Gotcha. Great. So based upon this PFO morphology, what size device you think fits? Has anybody used cocoon device? Okay. So Jay, tell us what size device would you use in this patient? To the microphone.
So
I didn't see the measurement, but however, the 25 millimeter device works for most of the
25 with 18 left disc or 25 with 25 left disc?
25 with 18 is enough, I think, because I didn't see any the big a little bit. 25, 25. Okay.
25, 25? Tao?
1825.
18, 25. Anybody else?
25, 25.
Okay, so we heard from 3 very experienced gentlemen. 2 want 25, 25 PFO device, 1 wants 18, 25 PFO device. What is your plan, Warakan and Dr. Hara?
Allow me to translate this to Hide a bit because he doesn't have a microphone now.
Okay.
But the expert in the room said 25, 18, 25, 25, or 25, 25. So what do you think?
Oh, yes, the very nice question. So if you look at the floor here and also the balloon sizing, I think it's going to be smaller than we had expected. I think it is less than 10 millimeter, correct? So 13.
30?
The weight is 7.
30,
The
30,
weight-
30,
the waist
25?
is
What?
7 millimeter.
Okay, yeah, I think, yes, if the patient has a huge atrial septal aneurysm, we need to upsize like a 30, 25. But in this particular patient, I think it seems 25, 18 is going to be enough.
And I do agree with Hide that we're going to go for 25, 18. Tawai, what do you think? Oh, by the way, Tawai from Rajavithi Hospital, thank you very much indeed for coming.
Yeah.
So this device goes
I agree
through
with you.
8
Okay.
French sheath, is that correct? I
25,
saw it on
18.
the chart.
Yes,
Okay.
I think as French sheet, right? Sheet 8 French ใช่ไหมครับ Yeah, now CC gonna or who gonna load that?
Welcome. I'm in the meantime, do you prepare the device? I'm a
Yes.
little confused still because could you be more clear or practical and how do you decide what aspects you to take in account to decide the size of the device you will use?
All right. Allow me to start first, Francisco. Very important question, and then we'll ask Hide to add on it. So I personally will measure the distance between the tunnel. I mean the PFO to the aortic wall. If that is something like 14, for example, I multiply by 2, it's going to be like 28. So the disc should be around that, should not exceed 28. So that's my first thought. And if you have the aneurysm, for example, I need to somehow add a little bit more millimeter in order to sandwiching or sealing the aneurysm just to make sure that, it completely block the flow, less residual shunt in the future. And last but not least, I have to make sure that that device should not impinge the aortic wall. So that's my thought.
Warakan,
I'm not sure about what are the practices.
Dr. Ekaji has a comment.
Yeah.
Yes, JT, please.
Yes. I think it's for the PFO, it's a not so serious device sizing. It's every device can be put in. But in the probably smaller device size, diameter of the left atrial disc may decrease for the atrial arrhythmia after the deployment. And one more thing is larger device in the right atrial side may have a higher residual shunt rate. Because that is.
I completely agree with what Dr. Kaji is saying. Larger device has inherent risk of having intra-device shunt,
yes,
which could be a nightmare to take care of in the future. And also the risk of arrhythmia exponentially increases with larger device. In my mind, I would put an 18 device here, if you ask me. But everybody uses 1825, so there's nothing wrong with it. Okay?
Thank you.
Yes, sir.
And this is the PFO device. So this is a left side disc, which is 18. And this one is a right side disc with 25. So it's screw and knot thing.
Okay.
And then we will load it under the water. Okay. So now we are ready.
Okay.
ACT ดูแล้วเนอะใช่ไหม ACT
I would continue, but Tao, we have a comment? No, please. Doctor.
Short comment. How many of you have had in the past
เคจ๋า
unscrewing
เอาหู
problem?
ไปได้แล้ว
Unscrewing.
Unscrewing?
Yes. When you decided this size and you put your implant, you had some problems with unscrewing.
Only if I tighten it too much. That's why I don't.
No, I think this is a very important issue, Zahid.
Yeah.
It's not. This is not a self-centering device. So many times when you try to unscrew, the torque doesn't get transmitted like it gets in a self-centering device. So my suggestion is that you tighten it and leave behind, come back one, and then you will never be. Otherwise, I have seen this umpteen number of times happening. So, we think it's a straightforward thing, but because it's not self-centering, unscrewing is a problem.
It can be a problem if you tight too much. I agree. Okay.
Yeah, by the way, before we continue, just I forgot to introduce, the great team here. Dr. Maka from Rajavithi Hospital, Dr. Chanika from Central Chest Hospital, and CC, and Bumbim, the nurse, and Tawai over there, and M. Yes, please, continue. So what Maka is doing now, he's about to open the disc. Yeah.
Nicely done. Morgan, is the cable stiff or is it a softer cable at the tip?
it's a cocoon cable, which is well, it's how can I say? It's not really flexible at the moment. I think in the future they're gonna make it more flexible, but now it's conventional original one.
Oh, 1 second. There's a comment. Go ahead.
Should we do the bubble test again to confirm that there is no extra cardiac shunt?
That's a good question. Well, we will come back to that later.
We'll blame
But
Tao for
Tawai,
that.
if you can share some thoughts on
Especially if
this.
it's late.
So the device well seated, and there's no flow across the entire system right now.
Okay.
There's no compromise of
This is a very nice profile of the device.
PV. Yep.
Question to Zaid.
Is the device unscrewed? Not unscrewed yet, right?
Are you still attached to the cable, right?
Not unscrew.
Now it is unscrewed. Okay. Well,
Zaid, I have a question to you.
yes, sir.
Yeah. In this echo view, it is the LA disc is nearly touching the transverse sinus.
Yeah.
Before they use the upsize, the more larger device, they may encroach onto the transverse sinus. So you don't like that, right?
For ASTs.
Okay.
PFO is a wiggle room, right? It's a non-self-centering. So non-self-centering, you have a lot more liberty of this. But if you have if it was an AST device, you should worry about it, yes.
Guys, sorry to ask, but the patient seems not be tolerable enough for the GOE at the moment. So if you allow us to, you saw the bubble test, right? I'm not sure you see it or not, but now there's a less bubble crossing through the left atrium, and there is no other like pulmonary venous shunt through. So if that's okay with you guys, I think we're going to release this device.
I think you should release the device. You can take the T-probe back, and then we can have a little bit more discussion.
Yeah.
Because I need to figure out how many people balloon-size PFOs and why.
Yeah, please. Then that's okay if we release.
Okay, please do. Is it difficult to release?
Not yet. Hang on.
Oh, I thought it was Tau.
Okay, not that difficult, huh?
Yeah, Dr. Tao thought it will be very difficult. So.
All right, so any other issues?
So, Warkan, when do you balloon size PFOs? Or do you ever balloon size PFOs?
Well, if you ask me, I do not do balloon sizing personally for PFO, but here they do some, right?
Oh yes, because in Japan, for the educational purposes, when we Japanese PFO Council recommend to do balloon size when the institution starts the PFO closure. Yeah. But if once we are accustomed to use that, I think we can skip it. But we need to be very cautious if the patient has a huge atrial aneurysm, and or if the patient has a platinum-also deoxia, in that situation, PFO is going to be so large than we had expected.
Okay, so how many people balloon size PFOs? Raise your hands.
Yeah, would love to hear.
Okay, it's a minority, huh? Sorry.
You know, here, the panelists, we have a discrepancy.
Go ahead.
You use sizing balloon for the PFO, and you don't. So give us our point of view about that.
Yes, well, actually, I'm not responsible for the PFO closure in our institution. The adult cardiologist is responsible. But generally, in Japan, the balloon sizing is recommended
for PFO in Japan,
especially in the beginning of the operators, the first initial experience.
And I am also a pediatric cardiologist. I close PFO, but not too many cases, and I've not used sizing balloon. Even for AST closure, very rarely I use sizing balloon for AST closure and rely on the T and transthoracic echo sizes only. And no problem. I had no problem during the past year, and I did not use the sizing balloon. I have no complication regarding the size.
Okay. Che, what do you think?
I think that I know that the many operators who has a lot of experience, even they don't size ASD. Many people are sizing the PFO because PFO gives another the other idea on the behavior of PFO itself. Sometimes squeezable, sometimes the long tunnel can be shortened. So such information may be provided by some balloon interrogation, not sizing actually. So not all the cases, but in some complex anatomy, I usually do the balloon interrogation.
Dr. Akaji?
Yes, I personally almost nothing to do the balloon sizing in my practice. But in case of in the ICE guidance, just the sedation, the balloon sizing is a little bit much more information about the shape of the PFO. So the ICE monitoring, balloon sizing is a variable.
Thank you. I mean, I think it is again, from my perspective, I rather balloon size PFO and never balloon size ASDs. And remember, ASD is a whole, right? So it has but PFO can be a three-dimensional whole because you have left to right separation, you have anterior posterior separation, and then you have tunnel formation, which is superior inferior separation. You have 3 degrees of separation. So if you have, this case was a simpler case. There was no aneurysm. If you have aneurysmal septum, and the amount of shunt that you saw, you have to worry that in the anterior posterior dimension, this is a very long, or what we call lunar shaped PFO. And that you can only tell if you balloon size how big it is. So in those circumstances, I think balloon sizing PFO is of crucial importance, if you ask me. Tao, what do you think? I know you have done hundreds of PFOs.
Inside, in what way a sizing balloon would change the selection of the device? If you have a large sizing balloon diameter, you will change to an ASD device?
No. So it will tell me how long the tunnel length is, because it's a very aneurysmal septum. It will tell me when you inflate the balloon, what the anterior posterior. In one view, when you measure, the PFO will be much bigger. In one view, it will be very, very small, in short axis and by long axis view.
Well, in that case, you will choose a larger left disc?
So, okay, that's a long discussion, but if you have a very long tunnel PFO, then I usually use a balloon, tip of the balloon, put the balloon in the left upper pulmonary vein, inflate the balloon like with a wedge catheter and pull it down to see if the tunnel is compliant. If it's compliant, you don't need to oversize the device because the device reconfigures and closes it. If it's non-compliant, then you have to rethink about it. I see Dr. Sievert is also there, and we are almost running out of time. Dr. Sievert, what do you think about balloon sizing PFO?
So I did it always for decades, but more recently I'm changing for angiography of the PFO. So, and that gives you almost the same measurements as with balloon sizing. So the technique is you have to use a big sheath, the regular sheath what you use for the device closure, have the wire in the pulmonary vein, bring the sheath directly to the orifice of the PFO and inject with high speed. High speed means 30 by 20, 30 cc per second, 20 cc volume. And when you do that, you get almost the same diameter as with balloon sizing. You can also see the compliance. And so that's actually my preferred technique now. And only if I cannot visualize the PFO with that technique, then I go back to balloon sizing.
Okay, that's a very important point. Any other questions or comments? Oh, Tao, please.
Never balloon sizing, even ASDs. The only PFO I was interrogated with balloon was with Horst Sievert when we decided to measure the length precisely of the tunnel. So interrogation is for that purposes because we were using at that time in tunnel PFO closure.
I think Dr. Sievert doesn't seem to agree with you.
I mean, not sizing, not do any sizing for PFOs is okay in 99 of 100 cases. But in one case, you will be misled. And then I think the biggest PFO we had was 27 millimeter. 27 millimeter balloon size diameter. That was the diameter I always sized. And that was not visible on echo. We saw a septum aneurysm, but we would never estimated that kind of diameter. So that's why some sizing is necessary, either balloon sizing or angiographic sizing. I wouldn't do it without any sizing.
I agree with Dr. Seward. I think balloon sizing in PFO is more important than balloon sizing in atrial septal defect. But any other questions, comments? PFO is always, to me, I always say PFO is potential for opening. Could be very big potential or very small potential for opening. So any other questions or comments? Yes, sir? You're running out of time. I know.
It may be a primitive question, but I don't understand what is the self-centering mechanism you mentioned.
Okay, we can discuss that after we. So we don't have sinus venosus ASD taped case, and we are running out of time. So I think this is the perfect timing. So I want to thank my co-moderator and the panelists. Thank you very much, and it was a fantastic discussion. Thank you.